Good afternoon, everyone. Thanks for joining the dermatology webinar. My name is Dr. Nazim Hussain. I'm a GP and the clinical lead for the dermatology well transformation. We are delighted to have Dr. Rebecca, who is a consultant dermatologist at the Royal London Hospital, and Dr. Jinesh, who is a GP with a special interest in dermatology. A couple of updates. We have sent off the orders for the dermatoscopes. Money has been paid, and because we have placed a large number of request numbers in terms of dermatoscopes, it's taking a bit longer than we expected, but hopefully we should have the devices with us very shortly and delivered to your practices with the associated teaching education, which is scheduled later on. And we will start very shortly now, and I will have to leave at 2 o'clock, so I'll hand over to Rebecca if we do run past 2 o'clock. This webinar will be recorded and will be available on the Well Dermatology site very shortly. Please keep your mics on mute unless you have a question to ask. If you do so, please raise your hands. And I'll hand it over to Rebecca. Thanks, Rebecca.
Thank you, Nazmul. Thank you very much for organizing this webinar to talk about teledermatology, or advice and guidance pathway, and what's working well and what needs to be improved. I'm just going to share my screen. Just take a few seconds, please. And thank you, Jinesh, as well for joining us. Jinesh has been key to helping with collecting the survey. So today we're also going to talk about some of the comments and feedbacks that we received from GPs and a few patients as well. So while I upload my presentation, the recording of the webinar is going to be available for you to watch later, but please do not take any photos on your phones of this presentation because it contains patients' photos too. So for those of you that may not know, we have been running a teledermatology advice and guidance pathway since 2018, and the inclusion and exclusion criteria have not changed throughout this time. So just to remind, because I cannot really recognize the names of the GPs, I hope you're all using teledermatology, but just in case you're new to this, our teledermatology pathway is open for adults, patients age 16 and above. We tend to receive consultations about different skin inflammatory conditions, acne, eczema, psoriasis, hair problems, nail problems. We accept some pre-malignant lesions, actinic keratosis, Bowen's disease. We're happy to advise about low-risk BCCs. But our main exclusion criteria, and this is important, is we are not giving advice about children. That's a different pathway and is under pilot at the moment. We do not want to receive to-be-wait referrals just to avoid delays. So any lesion that is suspicious of melanoma or SCC should go through the to-be-wait pathway. And we will talk about in a moment about the importance of this and also the importance of the dermoscopy for assessment of pigmented lesions. Also to remind you that we respond within 5 working days, but dermatological emergencies such as erythroderma or blistering disorders, is best not to contact us by advice and guidance. It's much better that you try to reach us by a switchboard to avoid any delays. And also, our advice is that you do not include photos from intimate areas, genital dermatosis, because this is what we decided at the beginning. I know sometimes some of you have done because you probably feel it's best for patient care, but it's just very delicate, and you have to have a very careful discussion with the patient about this because the photos are going to be stored and other people may be able to see those photos as well. So our recommendation is to exclude those lesions too. And just a reminder for those of you that are not familiar with teledermatology, our pathway is based on the British Teledermatology Society standards. Just to go through these very carefully, these are 8 standards. The guidelines is available on your website as well if you want to read this more carefully. And the main things that I would like to talk today is about how to gain patient consent and how to transfer the images safely. So about the consent, we are not asking you to attach the consent. We're just relying that you're taking the consent. It's your responsibility, but it's really important. The main thing that you need to explain to the patient is about the limitations of teledermatology, that obviously is not the same as the face-to-face consultation, and that there may potentially be difficulties making the diagnosis, reaching the diagnosis, and that it may be in the best interest to be referred at some point through the pathway. And it's also important to explain them who is going to take the photos, who is going to be seeing the photos, particularly if members of the admin team in your practice are uploading the photos, and that any doubts or that they are not in any pressure to give consent for this, that the alternative of face-to-face consultation is still available. Obviously, with the COVID pandemic, there are delays, and advice and guidance provides a much quicker advice within 5 working days. But this process of informed consent is key to avoid any disappointments or complaints from patients, please. We touched a bit about this, and this is all, as I said, these are the recommendations from the British Teledermatology Society. In terms of the photos will become part of the medical records. They will be stored in IMIS, and they will be stored in the ERS software in the electronic referral service. And the photos can be seen by other healthcare professionals as part of audit, as we're doing today, as part of teaching healthcare professionals. We are doing this with registrars in the department because teledermatology is part of the training, it's part of the curriculum. But that they also need to know that if they are going to be used for publishment or publishing or for teaching purposes, they will need the written consent. There's examples of the consent form. This is the one recommended by the British Teledermatology Society, and this is available in the WELL website, in the teledermatology website. And this is the teledermatology patient information leaflet and the consent form that we drafted at the very beginning in 2018. And as I said, this is really important that somehow you share this with your patient, either verbally or via AQRX or email or whatever, but it's really important that they have the opportunity to read and discuss any concerns. The last time we had a little webinar like this discussing teledermatology advice and guidance, we discussed some areas for improvement. So we had flagged that sometimes the referrals were slightly incomplete, there was not enough clinical information, and we suggested that you should use a pro forma that capture the minimal information for skin lesions and inflammatory dermatosis. Dr. Nazmul Hussain has actually produced a very useful one that contains all the key questions as recommended by the British Teledermatology Society, and then all the demographics of the patients populate automatically from IMIS. I think this is really important that we try to move on to this as quickly as possible, because around, I would say 20% of the referrals are incomplete, and this only causes more work for you, but then need to go back to speak with the patients, I guess, ring the patients again to ask for this incomplete information, and for us as well, because these patients remain in our work list. So in addition to the 75 to 100 patients that we receive weekly, we also have to keep track of those patients that are outstanding. The recommendation as well is to include at least 3 good quality photos, and 3 is enough. Sometimes we receive a lot more, and I think 3 should be fine, no more than that, but 3 good quality in focus with good illumination photos. Good light would be great. And something as well I would like to emphasize today is, ideally, under the standards of the British Teledermatology Society, there should be some form of patient identifier attached to the photo to avoid patients or misidentification. So it's relevant, particularly if there's someone that nominated at the end of the day in the practice to upload these referrals. Mistakes are very easy to make, and they may not be spotted easily. For example, if it's an admin member of the admin team doing this, because they don't need to know why there are different patients. And at least I have come across 3 cases where it was very obvious that it was a mixed. There was one child where the demographics were related to a child, the consultation, the photos were related to a child, but the attachment was from an adult patient. So it was very obvious that it was a mistake. There was another case where the GP was asking about a patient with a vulval dermatosis, but the photos attached were from the forearms. There was another case where the GP was concerned about an eyelid rash, but the photos attached were from a tattoo on the arm. So, and I don't even know if there are other mistakes that we obviously haven't realized. These were the obvious ones. So please pay attention to that, because these errors are easy to make. One of the exclusion criteria for pathways as well, that if a patient is already under the care of the consultant, we would encourage you to contact the consultant by email or contact our admin team via this email. rather than contacting us by advice and guidance, because obviously I wouldn't like to interfere in what other consultant has recommended before. And most of the times I'm only forwarding your query to the consultant. So if possible, try to contact them by email. And this slide shows the activity of our advice and guidance, and this is for the Royal London Hospital and Whipps Cross Hospital. The pathway started in June 2018. Well, the data that we're collecting here was from June 2018. I think we started even earlier than that. It was formally commissioned in June 2019 by Tower Hamlets. Whipps Cross started offering this around COVID, April 2020. So you can see how our activity, which is the red line, has gone through the roof. And we are trying our best to maintain the response times within 2 to 5 working days. And as you can see here, this is the blue lights. We tend to do this every month. At the same time, sorry about this, the previous slide. At the same time, this is what has happened with our referrals to be seen in clinic. They have reduced by 50% since COVID. And I'm sure this is not just the merits of the advice and guidance, it's just the pressure of what the instructions you receive from the Patient Transformation Board and COVID. And this is what is happening at the moment. So a large cohort of our patients we're managing by advice and guidance. In terms of our conversion rate from advice to referral, this we've been able to measure this more accurately since the conversion to clinic became a new functionality in February 2021. Before that, it was not that easy to measure because some GPs were referring at a later date using a different encounter, not necessarily the same encounter, so it was more difficult to measure accurately. But since February 2021, since we are able to convert ourselves, we know that our conversion to clinic is around 20 to 30%, which is in line with what other dermatology departments in the UK have reported with advice and guidance. So this is encouraging. This means that possibly around 80 to 70% of the patients you are managing in the community with our advice, which is encouraging. In terms of the two-way weight upgrades, which is something new that we are able to do as well from February, there's been some circumstances where we've been worried with the lesions that you've referred to us, and either because it was very clearly cancer or because it was not clear at all what was going on the photo and we didn't want to make any take any risks, we have advised to be weighed. And I do not have accurate data about this because apparently advice and guidance, the business intelligence unit do not collect specifically which to be weighed referrals, but having a quick look at the work list, the latest one, only 9 out of 193 were to be weighed upgrades, so not huge numbers. But the key message is if you're worried about to be weights at the moment, please do not use advice and guidance, use to be weighed pathway. This is the pro forma I mentioned before. This is thanks to Nasmul for putting this together, and I'm just going to show you this bits by bits. So obviously the top of it is the demographics, which I'm told this is easy, and Amy's populates itself. If Nasmul can comment on this later. The second box is just to remind you about the exclusion criteria, not to use when skin cancers to be weights, and not to use if we're talking about emergencies. If you're worried about erythroderma, a rapidly progressing rash, blistering disorders, patient systemically unwell, please contact us via switchboard. We are available 24 hours, 7 days a week. This is just a reminder about whether the patient has given consent or not. As I said, we are not expecting to see the signature of the patient, obviously, because patients you're not seeing them face to face, but we just want you to tell us, yes, you have had a discussion with the patient about the difference in diagnostic accuracy between face-to-face and teledermatology, and also whether the patient would be happy to use these photos for teaching purposes, and we can use this in the future to run more regular teaching sessions with you, to learn from advice and guidance, as clearly there's a trend on conditions that you sometimes need more help and more advice from us. The second box is the one that tells you the minimal information if you're concerned about an inflammatory disorder. And obviously there's quite a few questions of this, but this is the basic dermatology history. And if we are not giving this a photo, even if the photo is really good, we might not be able to give you an accurate diagnosis and an accurate management plan, or a very specific management plan. So if you are able to fill this information, it will be really helpful and will save us time, and it will save you having to call the patient back again. And this is for lesions, and really important to know how long the lesion has been there for. Sorry, I'm hearing some feedback. If someone could, I think Amira, please could you mute yourself? Thank you very much. So really important to know how long has the lesion been there for. Is this rapidly growing? Yes or no? Is this causing any symptoms? Is it bleeding? Which is the location of the body? Sometimes it's not obvious from the photo. Any family or personal history of skin cancer. Ethnicity is important as well. As you know, some skin cancers are more prevalent in some patients than others. Risk factors, other medical conditions, important to know, for example, if the patient is immunosuppressed, if it's a patient with, for example, organ transplant recipient or HIV positive, they are more at risk of skin cancer. So all this is important, and what type of medication they're taking would be helpful as well, so we can decide if they would be a candidate for surgery or for other topical therapies, for example, that perhaps can be recommended in the community. And a body map is also helpful. As I said, it's not always obvious where the lesion is on the body. And then about what suitable images. So these are some specifications that are available from the British Dermatology Society, but in essence, good quality photo. The file should be JPEG file. It should not be open. It should not be processed into any other format. It should not be resaved into JPEG. It should not be copy and pasted into a Word document, and I'll show you why in a moment with an example. And ideally with natural light or with flash, and a couple taken photos from 2 different angles. So we, for example, are able to tell whether the lesion is raised, if it's a nodule, if it's flat, what's the size in 3 dimensions of the lesion. And then if you want to take a good detail of the photo, you should use the macro and no closer than 20 centimeters. And obviously this is if you were taking the photos yourself, and if that was the case, which I guess was what was the situation before COVID, and it would hopefully be the situation in the future when you are able to see patients face to face. If you're using your own mobile phones, you should be reading this guidance, the UK guidance of the use of mobile devices, because there are loads of information governance issues that you should be aware of. And this slide explains that all. And the best thing to do if you're using your own phone is to use an app like Pando, for example, which I believe this is the one that your CCG has suggested and has and it's NHS approved. It's compliant with all the information governance. The photos will not be stored in your, or they will not be mixed with your own personal photos, and it's password protected, so it's definitely safer. If the patients are using the patients are taking their own photos, they are, I believe in your case, they're transferring them to you via eConsult or via AccuRx, which is again encrypted. But be very careful if you're using your own emails, etc. And then this was a few months ago, the BAD, the British Association of Dermatologists, produced some guidance for patients taking their own photos. So the photos could be of maximum quality. And these are just this is available from this website, and you can print this, give it to your patients, or maybe add this in a link to AccuRx, so they have this information before they take their own photos. There are now very, very helpful videos that have been produced by the National Patient Transformation Program. They last for about 5 to 10 minutes, so I didn't want to play them now and waste our time. So it would be really good if you can then watch them on your own time. Really helpful with instructions for patients taking their own photos, for GPs taking the patient's photos, and also for the admin team that are attaching the photos to ERS. So the links are there, and I will forward them to you so you can watch them on your own time. And then from our perspective of seeing advice and guidance regularly, these are the common pitfalls that we see. So quite regularly, either the GP or the admin colleague forgets to attach the attachments, either the clinical photos or the clinical information. So that's easy to make, and we have to remind them to do it. And sometimes the photos are missing, or the letter is missing, or there are photos but there's absolutely no clinical information. And as I said, even if the photo is amazing, if we don't know anything about the history, we won't be able to advise. And in fact, we had been specifically told at teledermatology teaching sessions by other BAD, British Association of Dermatology experts, to not give any advice if there's no clinical information, because it's a medical legal risk. The same, for example, if you're telling us about one lesion, but you send photos of 2 lesions, we won't advise. We will only be advising if we have information about both lesions. And as I said, sometimes the description of where the lesion is or how widespread or localized the rash is missing. And without that information, we won't be able to give you specific advice about what's the right treatment. Because, for example, say that you're talking about psoriasis and you should only show me one leg. We need to know how much body surface area is affected, so we can advise whether this patient would benefit from topical steroids or would benefit from second-line therapy. So this is really important. Please to give us as much information as possible. We also find that e-consult, the PDF attachments, they are not helpful for dermatology. They don't have any questions specific to take dermatology history. They're probably designed for, general consultations, but the questions that they ask, they are not helpful. So if you're using those, at least, if possible, try to get some relevant information about the rash, the skin rash. Sometimes, as I said, photos have been copy and pasted into Word documents, and they shouldn't. They should be just attached as separate attachments individually. And then the other thing we find is that when the information is missing, what we do is we ask you specifically about whatever information we think we need, and we give you some time. And that case remains in our work list for weeks. And then we tend to go back after a few days or after a few weeks to see whether you have attached that or not. And after 4 weeks or so, if we don't hear from you, we close the encounter. And I don't really know if that's because you were upset because we didn't ask for more information, or whether the patient got better, or whether it was impossible to get hold of the patient. So if at least you could let us know what has happened, that would be helpful for us to keep learning from each other. But as I said, this is around 20% of the cases, I would say, that need more information, and it adds to the huge numbers that we're receiving and will result in delays of care. So just some examples I want to share with you. So this is a recent case where the GP had attached the photos to copy and pasted into a Word document. And as you can see, all I received was a photo of a mask and the t-shirt, and obviously that wasn't helpful. And this, I think, could have been avoided with attaching independently, please. I had to ask for more photos. This was a patient at the very beginning, was really good photo and really, really good description from the GP. So asking about 2 years ago, the lady noticed a dent in her forehead. She had been referred to another dermatologist, then moved to our area. It seemed to have appeared suddenly. It was asymptomatic, but the patient thought this was getting bigger and extending into the hairline, and the GP could feel an indentation. The skin looked paler and feel slightly indented. Does anyone know? Does anyone want to say what do you think this is? This is, I think, a rare condition, but this was diagnosis. It was everything we needed to know was explained here very clearly. Has anyone come across this before? I want Dr. Bull to comment on this. Dr. Richard Bull, can I put you on the spot?
Well, I'd just say how nice to get something as clear cut as that from a good history, because we could advise very quickly on that. The more fear, I presume you're after.
Yes, correct. Yes, so we actually brought this patient to be seen within weeks, because this condition, linear morphea and coupe de sabre morphea, can progress very rapidly, and the key thing is to arrest the process as soon as possible. Otherwise, the patients can end up with terrible disfigurement and asymmetry on the face, particularly children. So this patient benefited from advice and guidance, and she was in triage appropriately to be seen in clinic as soon as possible, and was started on methotrexate and prednisolone. Then this GP also made a correct diagnosis. This was a gentleman with this rash on his tummy. I thought the photo was brilliant, really good photo, and I only needed one photo, and the GP told me correctly that the rash had started after a tick bite. Any thoughts?
Lyme's disease.
Yes, Lyme's disease, exactly. So the GP her question actually was, do I need to wait for the serology or can I go ahead with the treatment? So it was a tick bite, and I thought that was a good reminder now that people are going to start going outdoors as mad, and I'm sure you're aware that Lyme's disease incident is increasing. We don't know if it's just that it's more reported or there's more awareness or that people are going outdoors more or just the climate change, but it's on the rise, so you have to be aware of that. You do not need a serology to treat. You just treat with erythema migrans is a criteria to treat. You don't need to wait for the serology to come back. And then the treatment is, as you know, doxycycline, unless they are allergic to that or unless they are children. And there are nice guidelines for that for you to read in more detail if you're interested. Then this was another great case that I received months and months ago. So she's a young lady that was reporting to her GP that every time she put her hands in water, within minutes, she was noticing this wrinkling that was like this, so obvious, and what was striking is it was so quick. Any ideas? What is this? No, this is a difficult one, and I don't want to put anyone on the spot. So this is aquagenic keratoderma, and this is just an exaggerated wrinkling of the palmar surfaces of the hands. And the important things of this is that could potentially be linked to cystic fibrosis. So your patients need to be aware of that, and if they don't suffer with cystic fibrosis, they may be carriers of the gene, and they should be offered the genetic testing. So this is why this is important. Then this was another great case that I received, and apparently this patient had been seen years ago and had been advised some diprosalic. So he was a gentleman who had had a tattoo, I think more than a decade ago, and the tattoo had not given him any trouble, and in fact he had had tattoos in other areas of his body and with different colors, but this particular tattoo was giving him trouble over the last few years, and it was being treated with different combinations of Fucipet, diprosalic, and it was just very tedious. It kept oozing and bleeding, and there was no stop. So I actually brought him relatively urgent because I was worried about an infection and about mycobacterial infection, which is one of the potential complications of a tattoo. It was deemed unlikely even when I discussed it with a microbiologist because his tattoo had been 10 years ago or something like that, ridiculous. But that was my main concern. So I did a skin biopsy and I sent it for culture, both fungal and atypical mycobacterial culture came back negative. But the interesting thing here is a very unusual histological reaction that we don't normally see with tattoos. What we tend to see, there are many different complications that can happen, different types of infections, and usually sometimes granuloma, sarcoidosis, or it can also cause a phenomenon can precipitate psoriasis, many different ones. But this one was particularly unusual. Even the pathologists were excited with this biopsy, and I've only found one similar case in the literature. So what's happening here is that his body is trying to get rid of the red pigment. It's just specifically where the red pigment is. And it's just like what we call a perforation. So the red pigment is trying to go through the epidermis, out it goes. And only when he gets rid of the red pigment, this inflammation will stop. And I'm actually managing to treat him with topical steroid under occlusion with tape, fludroxycortide tape. So this is the photo that we took in clinic before, on the first day that we saw him. So as you can see, not very dissimilar to the good photo that the patient had taken before. So it was a good quality photo as well. And the photo on the right is I think it's the last photo when I saw him in clinic a few weeks ago. So it's slowly healing and he's much happier. Then moving on, I'm just going to give you a few examples of the challenges of assessing lesions by a teledermatology and why we are not keen on receiving lesions that are suspicious of TB weights because potentially we are in medical legal risk. I want to include a photo that we received yesterday, and I think this lady won the award of the best photo yesterday. She's a lady that had even included a measuring tape, and I thought this was fantastic, really good quality photo in focus. Anyone wants to suggest any diagnosis here? She's in her 70s, and this is on her lower leg. Does anyone want to suggest? No? First thought, maybe people may think perhaps this is granuloma annulare. It's a good thought, but usually with granuloma annulare, or sorry, not usually, always with granuloma annulare, there's also only dermal infiltration. There is no epidermal changes. This one, if you zoom in, which is what we have to do, we have to zoom in the lesion. You cannot do this with my screen. When you zoom in, you see there is some epidermal change as well. There is some keratosis. There's some what we call the little wall of China, which in clinic we will feel with our own hands, and this is what we cannot do with teledermatology, and that's what histologically is the coronoid lamella, which we see in porokeratosis, which is common on areas of chronic sun exposure, particularly common on the lower legs, and it doesn't necessarily need to be treated, and we are not keen on treating them below the knees because it can only end up potentially even in a wound that can take a long time to heal and cause more harm than good. So what we recommend is sun protection, self-monitoring, and if at any point it changes or grows quickly, to let us know, because that could be a sign of transformation to skin cancer, squamous cell carcinoma, which in fact it's quite controversial whether that is strictly linked to porokeratosis or is just related with the fact that it arises on areas of chronic sun exposure. So just monitoring is okay. This is another example, and this was a lesion that I actually upgraded as a 2B weight years ago when the option of upgrading our cells was not even available. And I'm not going to forget this case, I think, because it was really extraordinary. So this was a young woman who had gone to her GP with a lump on her leg that apparently was not responding to fusidine cream. And I think it had been treated like an inflammatory, perhaps ingrown hair or dermatofibroma. And I honestly didn't think this was going to be anything to worry about, but our schemes and our ways of thinking is if you see a pink nodule, you have to look at it with a dermatoscope because you cannot rule out a melanotic melanoma. So following that way of thinking, I said I need to bring her as a 2B weight just to rule out a melanotic melanoma. She came to clinic, and this is the photo that one of my colleagues took in clinic, and she even thought this was going to be a dermatofibroma, but because I had written I wanted to rule out a melanotic melanoma, she organized excision of this lesion and ended up being a leiomyosarcoma, which is a rare, extremely rare, an aggressive, locally aggressive type of cancer. So we did the right thing, upgrading this as a 2B weight. So, but this is just an example of something that honestly it looked quite innocent on the photo, and that is why when we look at lesions, we are very careful, and you may have seen some of our responses disappointing because it looks like we are upgrading stuff that doesn't look that worrying, but we just want to sleep at night and not being worried about things that we were not 100% sure what it was. And we don't want you to put yourself be put in a difficult situation that you were told it was okay and then it wasn't okay. So until we have the opportunity to attach dermoscopic photos or become more experienced or more confident, we are probably going to be upgrading lesions that are nothing to worry about, but this is where we are. And then this is a case I received yesterday. I'm only copying the text and not copying the photo because the lesion was on the groin and I don't really have permission to use the photo, but this GP was worried about a lesion on the right groin that she thought it was a severed keratosis. But I'm not giving any information here about how long this is been there for, whether this is changing, whether this is growing. I don't know what's the skin type of this patient, whether there was any personal history or family history of skin cancer. So there's nothing here for me to make any risk assessment. So I'm not including the photo, but I'm including a very, very similar lesion. And this is, honestly, believe me, it was very similar to the photo I had attached yesterday. And it was just a deeply, Matt, please, could you mute yourself? Thank you. This is very similar. and it was just a deep, darkly pigmented nodule. And I can't really reassure you that this is seborrheic keratosis. I cannot really rule out a melanoma, because we just need to look at it with dermoscopy, to look at these very, very subtle changes with dermoscopy. I'm now confident that this one, which is my case, not the case that I was referred yesterday, this is seborrheic keratosis, and then I can reassure you. But without it, I cannot be confident. And then, so I had to just suggest refer to clinic, but if there's suspicion because the lesion was rapidly changing or recent onset, please use the 2B pathway and use your judgment, because I do not have enough information now to make the decision. This is another case of mine. This wasn't from advice and guidance. This was a 2B referral. This was a mole that was around 6 millimeter diameter, and I'm sure you would all agree, clinically, it doesn't look that worrying. But the history was very clear. The mole kept getting irritating, itching from time to time, and it was different to the other moles. And I knew it was different to her other moles because I could see the patient in person. But if you send me this photo on advice and guidance without any other mole to compare, or without any clinical information and without dermoscopy, we won't be able to make a right and informed decision. So with dermoscopy, and we will be talking about dermoscopy in the teaching session that Nazmul has organized, there is an area here at around 7 o'clock, which is what we call the milky red area, which is neovascularization. And that is the clue here that this was a melanoma. This was an in situ melanoma. But again, that's the reason why our concerns with the pigmented lesions, and that's why we would not be happy advising about pigmented lesions by advice and guidance without dermoscopy. Any questions up until this point, or are you happy for me to move to the evaluation and have the questions in the end, at the end? Okay, so I'll move on. So the next part of the talk is going to be about advice and guidance, the evaluation, and I want to thank Gines Datani, a local colleague of yours, GP, with a special interest in dermatology. He's working with me on Wednesdays, and he kindly helped putting together the questions for the survey that then we circulated to GPs and patients with the help of Roberto, Nazmul, and Angela Puri. And we've received 39 responses from GPs and only 4 responses from patients, which is disappointing. And I understand you are trying, or your CCG is trying to get more responses from patients. Feedback from GPs to start with, and really pleased to hear that you found this service so helpful. First question, I found the advice and guidance to be useful and receive a timely response. That's the great majority, strongly agree or agree. It reduced the number of referrals, and the large majority strongly agree or agree, which is great. Thank you for that. And apparently increased your learning and provided a form of professional development, and a large majority would very likely use the service again. So that is great to hear. Really overwhelming positive comments, which we are very grateful, and we're just going to leave you a few moments to read this. And more positive comments, which is fantastic. Thank you for this. Sorry, I want to go back to the previous one. We also sadly received some negative comments, including some B words that I'm not going to repeat. And I'm sorry if some GPs found us that we moan when we ask for more photos, when the photos are blurred. But I'm sorry, but we cannot be confident. We will not be able to give a specific advice. And I'm sure you will all understand that radiologists will not accept reading a blurred X-ray, so we can't really accept a blurred photo. So we just have to try our best to improve the quality of the service. And some GPs have commented on the technical glitches, and some GPs have said that the service is clunky. And I've just shared with Nazmul and Roberto, there's a company called Synapsis, which apparently offers a much more user-friendly service. So we're looking into that as well, because also from our end, from the consultants, and we're not great fans of ERS. It's quite slow, to be honest. Some more comments here. Another negative comment about 2-week waits, that this particular GP found that he was left to make the decision in the end because we were not given a specific advice, and I hope I have been able to illustrate with previous examples why we get so worried and why photo in itself is not easy. And then you are asking for more PEDS, teledermatology, and I know this is some area that the department is looking into, and they are doing a pilot, and you will hear from the results of that pilot very soon. But at the moment, our pathway does not accept pediatric dermatology, and those will be rejected. And you are asking for more teaching sessions, which is what we're trying to do, and I would like to include more of these cases. They are great cases, honestly, they are really fantastic, and they're also very seasonal. For example, with the COVID pandemic, we've been seeing lots of cases related with COVID toes, COVID rashes. It's like a thermometer, to be honest, of the COVID in the community. So I would like to share more of this with you. So if you can tick the box that the teaching permission has been given, that's great. And then patient feedback, as I said, only very disappointed that only 4 patients have responded, but also the comments are obviously it's not very representative at this stage. But the key message is they would prefer to be seen actually rather than teledermatology, and they were not given enough information about teledermatology, or they claim they were not given enough information about teledermatology. And they would prefer to be seen face to face, and they not necessarily would consider this service again in the future. So as I said, we're trying to get more patient feedback, but the comments that we received is this was not explained to them properly. And I don't know if this patient mentioned about the treatment or the advice we gave or the process of teledermatology itself. So this is an area to look into as well. So my summary is, I think ING is working well. It's definitely providing quick responses and apparently also teaching you some dermatology, which is great to hear. There's no doubt it's helping us to manage a large proportion of patients during the COVID pandemic. It's not helpful for pigmented lesions without dermoscopy, so please remember not to use it for now until we have we discuss what's happening with the dermatoscopes and whether we change the pathway or not, but not at this stage without dermoscopy. It's not working if the photos are poor or if insufficient clinical information, and forward you the links for the videos and the format for you to start using, please. Blisters, please do not use the service. Contact us via switchboard. Just bear in mind the risk of patient misidentification, and this needs to be flagged and addressed. If there's any training that needs to happen, please think about this. And then in terms of patient feedback, seems like we need to improve the way we communicate to patients this teledermatology, and I would also welcome your thoughts about this. And I want to thank again my excellent colleagues. I just have included some photos of people that you're getting comments from, the responses from Professor Vicky Jolliffe, Dr. C. Hassan, Dr. Sarah Mertens, Dr. Richard Bull. He didn't give me his photo, but he's today on the call, so maybe he wants to switch on his camera so you can say hello. Dr. Liat Sarnas, he was our clinical director, and she was key helping us develop this service. Dr. Roberto Thompson-Gunn, Dr. Sasha Dot, who was key as well initially when we piloted this at the very beginning. Dr. Nazmul Hussain, you already know. Hello, Dr. Bull. And then our managers, Raja, Chris, Finemo, Marcia Lacey, and your CCG managers, Aida, Simon, Jessica, and Angela Puri, they've all been great, and Wayne as well. So thank you very much, and some reference as well if you're interested in reading more about teledermatology. I'll stop sharing my screen now.
Thanks, Rebecca, for a fantastic presentation and sharing those slides, which was really useful. The key thing is really avoid sending any pigmented lesions. Make sure your history is as comprehensive as possible and send good photographs. I think there's lots more to develop on advice and guidance. There's new technology coming along to ensure that referrals are seamless as possible, and lots of IT stuff coming up. So, are there any questions or any comments people have in the group? Okay, I can't see any quick. Dr. Bull.
I wondered whether, from our side, to help with the patient, is whether there should be a question about what the patient wants from the consultations. So, because I suspect when I'm answering it, I'm doing very much as a doctor, and I'm being sort of factual. This is what it is, and this is what you can use. But it may not address what the patient's concern is. So, just if that's another way that we could help you more.
Sure. Yeah. Good idea. I mean, I think most patients would prefer to see a consultant face to face, but the reality is, it's not possible, and the data, 4 out of 4 is a bit skewed. So the vast majority of the patients, in my experience, so I've referred to A&G, have had given wonderful feedback, because it meant that actually they don't need to come into the practice, they don't need to miss their work to go into the hospital. And a lot of the cases that I've referred to A&G I've managed in primary care. And it's meant the patient has not been inconvenienced. We've saved the NHS money and reduced the risk of COVID. And I think this is probably the way we're heading. A&G, not just for dermatology. I mean, there are other specialities in which the A&G function can be utilized, and I think that's what the trust is looking at. We're not asking you not to make referrals to dermatologists. What we're doing is perhaps get those patients that need to be seen in secondary care triage first before booking an appointment and finding out patient has not attended, or their condition has resolved and they don't turn up for the appointment. So that's the thinking behind using A&G more. But my conversion rate into kind of secondary care referrals through A&G is extremely low. Most of the patients I kind of manage remotely, and patients are generally happy. Patients who are generally happy tend not to give feedback because they're content. Those that are upset and angry will utilize the energy and the pressure to give feedback. And but feedback is useful. We need to listen to patients and see what they want. And we do need a broader spectrum of numbers to see what the overall pictures are. So if there aren't any further questions or comments, I'd like to close the case, but I'd just like to say that the dermatoscopes are in manufacturing mode as we speak. The company is overwhelmed with the sheer numbers that practices have pursued. So the company is busy making the devices, and they'll be out very soon. And once we've got it so each practice will have a delivery rather than collect it from a central hub. And once you have the devices, we'll provide the education and training around how to take the images, what app to download, and lots of other very interesting and exciting teaching and education sessions. So I'd like to thank the panel for presenting, and have a great afternoon, and see you at the next session. Thank you. Bye-bye.
Thank you, everyone.